start off with, I guess since you're here, you can tell me a little bit about the cap that I'm wearing today, right? And what's up, that because it's an important date for you and I, and we run these meetings. So figure I'd be indulge ourselves to talk about it. So can you tell us what my hat's about?
Sure. So 5 years ago today is unfortunately was a tragedy of Marjorie Stoneman Douglas High School, where we lost 17 souls, teachers and students. And as most of you know, very difficult day for many parents who lost their children, a lot of the school teachers, and just the entire community. So this morning I was at an event where all the first responders were there, and it's very harrowing, just to be back on the school grounds and to see all the emotions still there, teachers, family members, parents. And what was interesting is that you had, because it's 5 years later, you have all the high school students who were welcoming us. You can imagine they were all in middle school or before that, right? And I stopped to talk to a few of the high school students, and I said, how does this impact you? And they say, the building is still up. We get red alerts all day long, right? And she said, we've seen the videos. So she said, even though I wasn't here when it happened, I basically am reliving this even as a student today. So it's just all very sad how this has impacted a community, how it's impacted so many lives. And more importantly, the parents is really what hurts me the most, the parents who lost their children, three of whom I knew. Those parents, I know those parents. So it just makes it difficult. And Chris Caldwell and Dave Miramontes and all those people who have told us, and Paul especially, been a great mentor for me, that this just doesn't go away. And many of you on the call have lived through many of these as well. Just a very difficult day. But grateful to have you, Paul, as a friend, as a mentor, and many of you on the call today. So thank you, guys.
And I was really, I got to say, is that for a lot of reasons, and it did, it has lived with Peter for a while, but the thing of it is that he was really very, very just instrumental in being there. And it was fantastic that he was right there and then taking a kid into the hospital and being there, that's dead right there in front of you, yet trying to do everything you can. It's a tough one, especially when it comes to these that's the thing, that's all these vulnerable populations that seem to be hit, and it makes it worse, whether it's a child, an older person. We had an event at the airport a couple of years earlier here at Fort Lauderdale, and it was in the baggage claim area, and a lot of the people were able to run away, but not the elderly people who are just down there to go on a cruise and all that. And it breaks your heart when you see such things. Last year, by the way, when we had a little session on this, if I remember, about this whole issue, and it was striking, and people expressed things for the first time at the Eagles meeting. I remember that session, and I was very, very rewarded by the fact that as I was walking out, everybody was grabbing my arm and saying, this is the best session I've ever been to. And so I'm actually thinking about maybe rerunning something like that again this year. And I wish Chris Cole was on, because he was one of the first people to ever go in to such a thing when he made it to Columbine. And that there's many others of you on the line here who have been into multiple casualty incidents. So far, with the Michigan State thing this morning, that made it the 67th mass shooting. And then to me, it's not a mass shooting, but the point is that there's multiple shootings, and one thing from active shooter, there were 5 deaths. And so out of that, and it just still, as of today, that's 67 since the beginning of the year. I think since the beginning of the year, if I added up real correctly, so you got 31 and 14. So, it's 45 days into the year, and it's just crazy. So all I can say is,
Paul,
yeah.
Paul,
Yes.
what I wanted to mention, I spoke to Kevin Mackey today, and I was talking to Juan Cardona, my EMS chief.
Yes.
Who's there are people who are still going out doing the rounds on MCIs and response to MCIs and triage. And the more you hear, the more you realize that we still have a lot of work to do with kind of figuring all of this out, right? So here we are in 2023, and it's still not being done correctly, even with all this experience, quote unquote, that we have. So it's still shocking to me, quite frankly, that the responses aren't as smooth as they should be. And maybe it's because they're happening in one community here, one community there who has never seen it before. And some communities are more ready than others. But Stein was talking about ramp triage. How many years ago was that, Stein? 4 or 5 years ago with Sophie Dyer at Eagles.
Yep.
And that's developing traction right now, right? So.
Well, let me say one thing about that, Peter, just to give everybody a break on it, is that if you've seen one mass shooting, you've seen one mass shooting, okay? And it's just like in our case, we didn't know where the guy was for about an hour, okay? So it wasn't necessarily, so it really, and I can name 30 things that went wrong, but overall, I think it went really well, when you put it all together. There's no perfect situation because you don't know really what's going on in every situation. There are multiple people, and there's a lot of decision making that has to go on. So I have to say, what we do is try to optimize the situation. That's what you're getting at. Stein, you want to elaborate a little bit on what Peter was saying?
Yeah, first I have a question. Peter, does your area have joint medical direction kind of umbrellaed over law enforcement and EMS?
So it's a great question. In both in Davie, Florida, and in Coral Springs, and especially in Coral Springs, we had several events prior to Parkland that had joined those forces together. And I often tell the story that there were 17 children who were shot and adults who were shot at Parkland who were brought out, who were all lived, and all of those tourniquets and chest seals were placed by law enforcement because of the training that my department had done. In Davie, Florida, we do MCI Mondays, where police and EMS train together on Monday at a church here that we have locally. And my EMS personnel now look like cops. They have all the ballistics, and the cops are carrying all the medical equipment. So one of the best things that Coral Springs did, and I have to give my chiefs and my city credit there, is that they implemented that combination training a few years prior to Parkland. All was involved heavily with that as well. So yes, the answer to that is yes.
Great, thank you for that. And Paul, to answer your question.
Oh, first of all, Peter,
yep.
You just also made my point for me in some respects, okay? But because it really did go well in many respects, so and you'll see. But go ahead, Stein.
Yeah, and as Peter mentioned, Sophia Dyer and I presented ramp triage. It was a few years back, and
right.
And my thoughts are that I believe that a lot of the triage systems fail. The traditional triage systems fail. One, because they are not in a vacuum. They're not in an area where everybody just sticks around. But for the EMS providers, we are asking, and for law enforcement, we're asking them to all of a sudden, in the highest stress situations, to change everything that they normally do, all the algorithms that they normally think of, and use SALT or something like that. And the way to succeed, I believe, is to move to systems like RAMP that don't actually change anything that everybody does every single day of their EMS career. And therefore, they don't have to stop and think of a totally different system, which is never going to happen. And Sophia mentioned that. The number one thing that she mentions about the Boston Marathon bombing was that every iota of training on mass casualty and all of the triage and everything went right out the window the second the bombs went off. And everybody just went to what they're doing. And so if we can normalize what we do in MCIs to mimic what we do on a daily basis, that's where we're going to succeed.
I think you're absolutely right. I don't want to sound, coming back to myself, but in 1986, I wrote an article for pre-hospital and disaster medicine that Mix works with. And I said 10 golden rules for multiple casualty. And rule number 1 was, follow your day-to-day routines as closely as possible, or change your day-to-day practice so that you would fall out there. So I absolutely agree with what you're saying, because after being in many of those, that's exactly what you need to do. Like, for example, I'll give you one quick example. People say, we're going to have code red, we're going to have code green, code yellow, whatever it may be. But on a day-to-day basis, if the police are using, code 1 is their, whatever responding thing. And then the EMS is saying code 3 is the more serious cases. Well, then we said, let's go red. Well, why don't we go red, green, and yellow on a day-to-day basis? That's how, it should be done under those circumstances. So as a good example, Kevin, go ahead and pipe in, and then I got to move on to some other subjects, namely AML. Okay.
Thanks,
Kevin?
Paul. Just quickly on the MCI, Paul, on the MCI thing, we just finished our after action review for the K
Yeah.
Street shooting. It's 176 pages long. And one of the things we're doing out of that is we've rewritten the terminology and also how we handle specifically an active shooter incident. So I can share that with folks when we finalize it.
When it gets down to it, to repeat what I just said, is that I hope I was trying to get all of my medics every time I was, running a system altogether, is that we would make sure that the police and the EMS, whether it's a fire officer or paramedic, whoever's on the scene, to connect. Then you're actually making a mini incident command post at that moment in time, wherever you are. So it just should come down to that on a regular basis. And I love what you're doing, Peter and Davey, with the MCI Mondays. That's a very cool thing, because you just got to get the drill down. I'll tell you what, the single most important thing I've seen in these events is that people know each other and they interact with each other, and that makes a tremendous difference. Kevin, did you have anything else, or just have your hand up?
Sorry, just had the hand up. I'll take it down.
Sure, Corey.
So I'm sorry, I confused my hand with my mute. Paul, it seems like based on the session last year,
Yes.
experience of a number of the people that are on this call, maybe you could lead a group of people that have done real MCIs and have dealt, unfortunately, with so many deaths, as to what works and what doesn't, in a really good position paper with a number of things to do and things not to do, and a consensus of experts kind of paper.
I'm kind of okay with that. We sort of did something like that with, I think, with the DHHS a couple of years ago, but I wasn't totally satisfied with the way it could have been simplified a little bit more. So that's, I think we should do, is get something that is a little bit more user-friendly and easier to, to translate and to teach and all that. The only thing I don't like is the issue of, reinventing the wheel again, but I'm really open to that. But let's talk about it. I'm going to put down the approach to triage and MCIs as one of our topics that we'll do at Eagle Creek this year, as long as with the trauma CPR and along with a couple other things that we'll be talking about there. So I think that's good. Anybody else? Anybody else want to make a comment on this? Oh yeah, David, go ahead.
Yeah, so I was going to say, in my organization, in big places like in DC and San Antonio, we have a lot of resources. It's really simple. You either red or you're dead, red or dead. And if you're red, we're putting you in an ambulance. We're putting 2 people in an ambulance, go. Another 2 in the next ambulance, go. Another 2 in the ambulance, let's go. And then whoever's left, who's walking wounded, we'll figure them out. We'll put them in an ambulance and we'll send them to the farthest hospital away from the scene to get care. So I think I really have changed based on where I'm at, right? And what my resources are. So if you're in a place with lots of resources, red or dead, throw them in trucks, clear the scene, and then figure out who's left. But if I'm in a rural place, like Uvalde, where the level 1 trauma centers are, 60 minutes away, then you got to do a little bit more differently. You may have to do more treatment on scene before you put them on a helicopter.
Okay. All right, anybody else before we move on to other topics? But this will be more to be discussed, but go ahead, Peter.
Yeah, I just wanted to make a mention that Dave Slattery gave a great NAMSP talk about sending EMS to the hospital and having them set up triage for the hospital. I thought that was a great concept as well.
Yeah, and that came out a lot in our after action report after Las Vegas, and that was very, very, very useful. And because sometimes you can't even get into the scenes when everybody is coming out, and it's great. And so it is important. The reason why that became important for, and particularly it became important for Las Vegas, because in Clark County, they had so many people shot. Most of the time, only 5 or 10% of people they're either dead, as he said, okay, red, but the red is usually only 5 or 10% in most multiple casualty incidents over the last 40 years. And we're not talking about nukes or anything like that. We're just talking about the train crash or the whatever, multiple shooters. But Las Vegas really changed that because they had so many people down. It was more like 40 to 45% were true reds and needed to be operated on. So there had to be some additional triage there at the hospital. So yeah, those plans have to be there in your back pocket at all times and set up in case such a thing does happen. So,
Hey,
all
Paul,
right. Yes.
it's Mike.
go
I'm
ahead.
sorry, I can't find my control for a hand. I didn't mean to butt in.
No, it's okay. You can interrupt. I mean, it's fine. I want people to interrupt. Okay, go ahead. What are you going to say, Mike?
We may have already discussed this, but I think Uvalde is a great example of scene control and incident command and who's in charge of that. You know, and I think maybe we've already been through that, but the idea, the IC, I think essentially has to be set up by fire or EMS. Police are responding tactically, and they're not really in a position to get the trucks out of the way and make sure we have ingress, egress, and all that sort of thing. I think that's really one of the fundamental things that needs to be discussed in this whole package as well.
Yeah, absolutely. And that's kind of what we were going to get into. There has to be a better coordination even on a day-to-day basis, as far as I'm concerned, with the law enforcement side. That's it. Glenn, you want to chip in anything since you are seeing these like almost every week? Glenn Aceda? No video, but I got an audio, it looks like. Hey, Glenn, are you there? We're not hearing
Hey, Paul,
you.
sorry. Can you hear me?
Yeah, now I can hear you. Yes.
Yeah, sorry about that. Yeah, we always have something small scale and, besides the major ones where, the red or dead makes sense on the smaller ones, but obviously the major ones, it just doesn't happen that way. But
Right.
it's always very challenging, like World Trade Center. Yeah, that was, beyond anything, but red or dead wouldn't have worked. Most of our people were, green and yellows, actually.
Yeah.
Because those that were in were dead. We didn't have that many reds. So
That's a point I make. I think it's something else I wrote or talking about that is that there was thousands of people killed, but in terms of people, let's say over the next, because I think I only calculate out to when we were at 2 a.m. the next day. So let's just say roughly 15 hours into it, there were only 50 to 100 people even in monitored beds, after that event.
right.
And so, yeah, it was less than that 5 or 10% thing we had talked about, all that.
Right.
But so, yeah, you have.
But
more
that's
stories.
just a massive incident that,
Yes. Yeah. Well, any event, but still, that's the point is that it gets back to my original thing. You've seen one MCI, I've seen one MCI, right? To some
that's
extent.
right.
But doesn't matter.
Absolutely.
You got to still continue to get better and tune up. I think a lot of things we have are people trying to, make it simple to train people and have kind of a cookbook, but there's no way. And I lean a little bit more towards, what David was saying in most of our stuff, but that there are other ones that we then have to adapt to accordingly. So,
Right.
All right.
Absolutely.
all right, let's see. Anybody else have any comments before I move on? I want to bring on Amal because we haven't had him talk, but for a little bit, but he's got a pretty good, I think a case or a couple of cases that we probably should know about, right, Amal?
Yeah, actually, related to an article. But
Okay, go ahead, give it to me.
yeah, this certainly pales in importance compared to what you all have been talking about recently. But I did want to spend just a few minutes talking about an EKG topic. I'm sure that surprises people, but this has to do with
EKG. Is that German for electrocardiograph? Is that what that
exactly? So
Okay.
ECG topic.
Okay.
Pertaining to hyperacute T waves.
Okay.
I'm sure many of you know that the JACC recently published a 2022 chest pain update, which went over a lot of new concepts and, well, maybe not new concepts, but for the first time they endorsed certain EKG concepts, including the Scarbosa and modified Scarbosa criteria as indications for immediate cath lab activation or lytics. And also they put hyperacute T waves in there as well. And hyperacute T waves have always been a little bit of a pet peeve to me because no one's ever defined what hyperacute T waves are. It's a very gestalty type of thing. Typically after the fact, the patient's been diagnosed with a STEMI, then you go back and look at the EKG and say, oh yeah, there's hyperacute T waves. But prospectively, if you ask people, is this hyperacute or not? I think a lot of times it turns out to just be LVH or just a young person with gigantic Hughes complexes or left bundle. So these are a couple of cases of chest pain that were diagnosed as STEMIs, went to the cath lab and turned out to be nothing. This was, these kind of look hyperacute-ish, and this went to the cath lab and was unremarkable. It's just LVH. Here's another one. This certainly does look hyperacute, and this turned out to be nothing also. So somebody finally studied this. This is an article in Press that I just came across in Annals. And in this article, they used a definition that perhaps some people have heard of, but what they said was they diagnosed hyperacute T waves when the T waves were greater than the 95th percentile of the size of the T waves in each individual lead in this large population, in a large database they had. So they compared the T wave size in each individual lead versus a lot of other patients. And if they're more than 95th percentile, they said these are hyperacute T waves. And these patients were followed up, and it turned out that this whole concept of hyperacute T waves had abysmal sensitivity and specificity. In fact, what they found was that more of the patients in the study with true STEMIs had smaller T waves than the false positives. And so hyperacute T waves are not all that. I think there's one time where I would really truly call something hyperacute T waves, and I've tried to teach this for a long time. And if essentially it becomes very simple. If you ever see a T wave which is larger than the entire QRS complex, in other words, you could take that entire QRS complex and fit it inside the T wave. That's always abnormal. You should never have a T wave which is larger than the entire QRS complex. And from my standpoint, that's either hyperkalemia or that's early cardiac ischemia. And God forbid, telling the difference between those two might boil down to do this old-fashioned thing called a history. But again, if you ever see a T wave that is truly larger, or rather, T wave that's truly larger than the entire QRS complex, that should always be considered abnormal. And what you do in that scenario, you just get a 12 lead. Here's a great case. This is a pre-hospital EKG, and I've got some others that are very similar that I won't bore you with, but this pre-hospital EKG, the paramedic looked at this and understood that this relationship between the QRS complex and the T wave is wrong. For the T wave to be that much larger, notice that there's no ST segment elevation anywhere, but because of that disproportion, he got a repeat EKG about 10 minutes later, and sure enough, this turned into a STEMI only 10 minutes later. So this is an indication to get serial EKGs. If you ever see that T wave that engulfs the entire QRS complex, to me, that's the true hyperacute T wave, but there really is no other definition that's been proven to be sensitive or specific. And so I think that if we kind of get that word out there, it might decrease some of the false, what they would refer to as false activations of the cath lab.
Yeah.
And also it highlights the importance of what Corey has always said, which is that one EKG begets another, get another EKG. And correct me if I'm wrong, Corey, but I recall at a conference one time, I actually asked you about this saying that you always have about repeating the EKG, and you told us that you read that phrase in the Bible, I think it was. Isn't that right?
During Hebrew school, while smoking something, it came to me as I looked at the Torah. But Amo, I would have been embarrassed on that first EKG, which has classic hyperacute T waves. I thought I saw an inferior MI there too. On the first one you showed us.
Yeah, let me go back.
That had a clean
Yeah,
cap.
there was nothing superior about that one for sure.
Yeah, this does have
Looking
a
at
little
lead
bit.
2 and F, I would have lifted the phone with classic hyperacute T waves and some subtle ST elevation in the inferior leads. I think the cath is wrong. I think I'm right.
You might be. This did turn out to have a negative cath, but here's a separate little pearl. I don't want to say anything in medicine is 100%, but very close to it. Inferior STEMIs pretty much always give you ST depression in AVL, nearly 100%. So the fact that there's no ST depression in AVL is really, really, one more time, really strong evidence that this is not an inferior STEMI. And that's been published before.
That's
But
why you're the master, my man.
so anyway, but thanks for your time, and I hope we can get that word out there.
Well, in my opinion, it's like, thanks for your time. Okay, really appreciate it. Thank you. That
Anytime.
was good. Anybody have any questions or answers for him? Okay, anybody else have, okay. Oh, Lakshmi said she had a great example of that on her last shift. Okay, so good. Important to serial EKGs. Okay. All right, hey, so let's do this. Speaking of that, especially since we have you here, Amal, there is a quick question that came up. I was looking to see if we can get others on. But Lakshmi, we were talking about treating people out in the field with STEMIs and all that. And is there any questions you have to ask about that?
Yeah, I'm glad I'm all on, and thanks, Paul. I just wanted to, there's been a relatively reasonable push among certain interventionalists here in Georgia about patients receiving pre-hospital heparin for STEMIs. And there are many services that are doing heparin bolus before they hit the hospital. We are not, and I was just curious about, and I looked at the evidence behind it and tried to look at the articles, and I was just curious about what the bigger EMS world out there was doing, and what our cardiology Eagles guru had to say about that one.
But you on
We
the spot,
use it
you
to
can come back.
diagnose dissections.
Yeah.
I mean, I have my reservations, and I'm trying not to, I'm going to save my opinion for later, but I wanted to kind of see what everybody else thought about this.
Yeah, so let me first start off with this, is that, and you don't even have to answer it today. If you want to come back and talk about it in more detail later, either professors there, either Matu or Slovis or anyone else, but go ahead and give us your opinions. Do you have one?
Yeah, I can give you my 2 cents. First of all, anybody who
By the
goes
way, there's inflation. It needs to go to 3 cents. Okay, so I want you to know.
I'll go back to the homeland. I'll give you my 2 rupees. How's that? That's worth even less. So
Right, good.
pretty much everyone who goes to the cath lab for a STEMI needs to be on heparin, but there's no evidence that giving heparin an hour early or half an hour early produces any benefit versus heparin bolus just before they stick the groin. So I don't think there's any good reason why heparin needs to be given pre-hospital. In fact, our cardiologists will tell us, if you want to give the heparin in the ED, that's fine, but don't delay it. Just get the patient upstairs. We'll give the heparin up here if that's easier. So that's
Is there any issues with storage or temperature or any of those other issues that we face in the pre-hospital?
No, there isn't actually, and that was the argument. I mean, it's a single dose, it's 5,000 units. It's not, there's no weight-related dosing that you have to do, and there's no storage concerns. So all that is, I guess, is in favor.
I think everything in medicine is a risk-benefit ratio, and you're
Right.
doing it on incomplete information. And the chances of converting pericarditis to tamponade with hemorrhagic pericarditis, the chance of a MI mimic as far as a dissection, there's no advantage, just as Amal was saying, there's no advantage of a little bit earlier, but there could potentially be a mortality increase for a non-beneficial drug.
So Abdo, you guys use it over in France, correct? Tell me about that. Is it because who's doing it, or what kind of personnel are using it in the pre-hospitals? You're doing both antiplatelets. What antiplatelets do you use? Aspirin?
Yeah. Yeah, hi. Sorry, I cannot. I'm a bit busy. At the same time, I'm working on my shift. Yeah, we're doing heparin, and we do also antiplatelets, aspirin, and Plavix or others, depending on the criteria. Whenever we have a STEMI, is really a STEMI with a mirror image in other leads. And usually our ambulances are staffed with emergency medicine doctors that take in charge of these patients and bring them straight to the cath lab. So
Yeah.
basically, we didn't report much adverse effects, and usually we have very rare, I would say, misdiagnosis.
Right. So, anyways, wanted to point out that usually the SAMU do it, but they're the emergency physicians that are out there doing it. I just wanted to show the differences there as well.
Yeah.
I don't know if that changes our opinion here, but still, I just want to make sure we know that there are positives for that, and that's why people are using it elsewhere. So anybody else want to pipe in on this or give an opinion about it before I push it back to Lakshmi? So I understand that you actually have insights because you're sleeping with somebody who's an interventionist. Is that right?
I mean, he had the same thoughts, but it's interesting because 3 major hospital
Let me
systems
explain
are
that.
doing it.
Her husband is a cardiac interventionist. That's why. So sorry.
Yeah, no, but I mean, he had similar thoughts, but 3 major health systems in Georgia are doing it, and a lot of hospitals in South Georgia as well, which is interesting.
Okay. Is there any rationale for it? It has to do with personalities sometimes, or people, or you have any reason why that is? Or
The good thing is our EMS system takes STEMIs to like 4 or 5 different hospitals, and to have 4 or 5 different interventional group practices agree on something is going to be hard. So I don't think I would have to make this decision anytime soon.
Okay, got it. So then the next question is that is the reason why they're giving it out in other parts of Georgia because of lengthy transport times or something along those lines?
Not necessarily, because 2 of the systems are urban, or at least suburban, and their transport times are not that long.
Okay, got it. Anybody else here are doing it here in the United States? Anybody in these large cities that we all operate out of doing it? Or had pressure to do it or recommendations to do it? Okay, so it sounds like there's no one else, but at least that's a great topic to bring up. And now you've got sort of an insta poll. We may even do a hard poll on it for you, but it sounds like just looking at the group here is that it doesn't look like it's widely adopted in the large cities in the United States, at least at this time. Okay, if that helps you. Good
Thanks.
question, right? All right, let's go on. And Peter, did you want to bring up this issue? I was waiting to see if Fiona or any of the folks from the UK were going to be on, but do you want to go ahead and address the issue of the strikes, or should I go on to the other topic about infectious disease, which David Miramani was going to lead?
Yeah, if you want to go do that, we could wait for Fiona, because I think it's a UK, it's really an America issue as well, but I'll leave it up to you, Paul.
Okay, let's start off. First, let's just get some quick reports, and then we'll go to David, because he wanted. I thought there was he and I had an interesting topic, conversation the other day, and I was hoping people like Eileen and Mike Osterholm was actually thinking about trying to get on today, but he was busy, but he's going to try to get on. So let's do this. First of all, any reports from ACEP that we should know about, Sandy?
Yeah, not a whole lot. Our PEDS meeting coming up in March in New York City. It's a really cool meeting, and think about going. We're doing a lot of work on boarding. We have, as I mentioned before, we sent a letter to the President of the United States regarding boarding, and are still waiting to hear. We will be having some type of a summit. The reports around boarding are just horrendous. We have a new section. I don't know if I mentioned this the last time. It originally was called at or nearing retirement. Now we're calling it approaching retirement. Not to say that there are a couple people on this call that might be in that category, myself included. What? Yeah. But,
Okay.
They had a bourbon tasting last week.
Yeah.
We're going to have a chocolate tasting in another couple of weeks. And it just is, I mean, it makes me actually think I should join the group that's at or nearing retirement. So if you're interested in that, get in touch with me or Steve Anderson. And then I just wanted to throw a note out that the International Congress in Emergency Medicine is in June in Amsterdam. I believe it's the 14th through the 16th or 17th. I don't remember. Anyhow, I'm going to be there. I think it'll be a really fun. I haven't heard a whole lot of talk about it, but it's really kind of a cool, those international conferences are great. And Amsterdam is like super. I mean, it's just such a city.
And we're gonna be holding an international meeting here in Fort Lauderdale area. So just want you to be aware of that too, that week of June the 12th through the 15th, 16th rather. So.
All right.
Okay.
I unfortunately will not be on that one because I am going to be on a cruise. The Rhine that ends in the ISOM conference. So I was made to screw you.
We'll have Jeff Goodlow represent ASAP there. He'll be there. So good.
Do a Great
All
job.
right. Anything else then, Sandy?
That's about it. All the
Great.
news.
Good. Well, let's go on to, we have some other things. When we talk about the strikes, if we get to that, hopefully you'll still be on and or we'll continue conversations about that. Because I want to know how are we preparing for it and what are we doing? And that goes back to the boarding issue. And and we'll love to be involved with that as much as possible. Okay, so anybody else on Doug, you want any report from out of NEMT from your end? Hey, Doug, are you there? Doug Kupis? Well, guess not. Okay. One of the reasons why I wanted to have Doug on also is to talk about another issue that and maybe Glenn, can you tell us a little bit about there was a white paper that came out in New York State. Can you tell us a little bit about that and what the implications are for you guys, or are there any?
Well, I'm not exactly sure which one you're talking about, but there's been a lot of things going on at the state here.
Yeah.
New York State does not have an EMS medical director, as most states do. We do not. So they're trying to do that. So they allow at the moment 10 regional districts for EMS, New York City, the 5 boroughs being one. They're looking at changing some of the rules to get rid of some of the regional emergency medical services councils, which now the state will want to take over. Part of the other things is that they want to have a statewide collaborative protocol where it's one protocol for all of the state. We've been arguing against that because what happens in the Finger Lakes region upstate does not work here. For example, they do not have a WMD protocol. So, anyone can get attacked. I understand that, but we seem to be a little bit more of a vulnerable target. So we have to have some kind of protocol in place. So there's a lot of working parts. They're trying to change at the state level, Part 800, Article 30, Public Health Law, that could change things as law. And so our REMAC, which I'll be heading to for a meeting in a bit, they're trying to figure out how to fight this. So there are a lot of things that are going on, and we're trying to figure out how we're going to land this.
Well, Peter, you want to bring up you're familiar with the white paper that went out, and what is it? Give us a 30-second summary of what you took away from it.
Yeah, so I think Ted just put it up into the chat, but it was basically the document is the New York State 2023 evidence-based EMS agenda for the future, and I thought it was very well written. There's a nice summary, executive summary page there, but it really, as I was reading it, I'm thinking, my God, all of us have the same issues, basically, that EMS is in crisis, essentially, from the sustainability to our workforce, to pay, retention, etc. And as far as EMS not even being considered an essential service, which reflects on funding and etc. So I think that it would be I thought it was a very good read, and that it really is just a microcosm of what's happening, I think, around the country. And as I was reading it, a buddy of mine called me. I trained at Children's of LA, and he's an ICU doc there. He said in the last 3 weeks, they've had 15 PICU nurses just up and leave. And I said, where are they going? He said, they're going to the PACU, they're going to other places. So it's not just EMS, it's nursing. That's why the wall times are so bad. So I'm happy to hear that Sandy said that they wrote a letter to the federal government, because, I mean, this is just a significant problem getting worse, and the next 5 years is going to be really a shit show unless we start taking care of it now. But I think everyone should read the article, the white paper.
Okay, got it.
It's interesting, the fact of state council saying that, oh no, EMS should be an essential service, this and that. like PD and FD. And I think a lot of people thought, what do you mean we're not essential? You know, that was one thing. And when they added that, that sounded good at the front end, but when you look at the rest of it, at least in the state legislation, they are adding a lot of these things that I had mentioned before, where they're trying to get the control out of the regions, which, you know, good or bad, who knows? You know, one state protocol, yeah, I know nationally, the National Registry's been looking at things, but it just doesn't quite work for everybody, but yeah, interesting.
Yeah, they would have to be adjusted depending on where you are, because there are such rural areas in New York, you know, and yet, you know, and then you're super urban, you know, in New York. So which makes a lot of differences, you know, in different ways. So not only traffic and high rises, but a lot of other things as well. Sheer volume sometimes. Well, John Kramer, let me turn it over to you, because you have dealt with this for a long time, and your reaction to that document that's in the chat is a positive one.
Yeah, I mean, I think it was very well written. It describes the problems well, talks about alternatives. Glenn, I didn't get the same sense that they were moving away from regional activities. I thought they were trying to encourage more support for the regional activities. So I may have misread things a little bit, but you know, as Peter alluded to, it really applies to almost all EMS systems around the country.
Okay. So Peter, anything else you want to add on to that, or just let's move on to the other subjects? Or are you okay there? Anybody else want to comment? Nick, did you want to, not Nick, I'm sorry. Ted, did you want to make any comment? Because obviously you read it if you sent it that way.
No, the big thing that I took away from it was, you know, looking at structure. One of the big components, because I have a EMS educational background, was the requirements for education and some type of standardized system. And then the requirements for like a common billing, I thought was kind of interesting as well. But I would imagine, like the discussion has gone, a lot of states and a lot of services are looking at all these agendas, and they're very common across the board. Everybody's feeling the same pinches.
Yeah. Okay. To close this one up, Jeff Jarvis, you want to make your point? I know you're doing a little tongue in cheek, but there's, I think the issue of allowing for innovation is really an important one to point out.
Yeah, it's just slightly tongue in cheek. Obviously, y'all know about Texas, that we have a delegated practice state here. And what that means is there is no state protocol. Each system is able to adapt and innovate to fit the needs of our system. If we had a state level protocol, we wouldn't be doing mobile integrated healthcare in Fort Worth. David in San Antonio certainly wouldn't be doing a lot of the wonderful stuff he's doing with opioid mitigation and homeless. So you wouldn't see any of the whole blood issues. We would be talking about this in committee for the next 10 years.
Yeah,
So,
right.
Yeah, there's a real double-edged sword to it.
One thing I would have is that hopefully there is some sense of checks and balances, or at least that as long as there's good communication with you all, hopefully we do some of that right here. Is really in case someone's out there just doing crazy delegated practice, you know, but you know, who am I to say that, right? To start off with, but so thank you very much for that, you know, comment and all that. I didn't get to see this very well over here. Doug is saying that I thought the New York was well written, so solution that your board rather than certification formalized. Okay, good. So maybe we'll have him respond to that later on. Just wanted to see. So any event. All right. Hey, Ray Fowler, how are you doing? We ought to just say hi to you. How's things getting along with you at this point in time? Any changes in your situation?
No change. Rocking along. The tests following care continue to show some tumor shrinkage and this, that, and the other. So far, so good. A day in the line.
Are you out in Douglasville now?
Yeah, I'm out of the cabin.
Good. All right. Fantastic. Good for you. Anything else to report from Dallas that you can tell us? Anything of interest, or just rock it along?
So many things political, you know, Dallas getting its contract renewed with UT Southwestern. We just established a new medical director for our system at large, a fellow named Andy Hogan, who's terrific.
Okay.
So we're rocking along, Paul.
All right, good. It's great to see you then. All right. So David Miramonte, speaking of getting away with things, right? No, I'm just kidding, David. No, but thanks for David is so good at doing some great advances, and I'm just always in awe how he does it all. But one thing that he and I talked about the other day was maybe how this latest versions of supposedly the epidemic is going to be over next month or 2 months from now. And so, what does that mean? And is COVID going to be gone away? And I think there are some changes. And I think that we know how different Alpha was from Delta and how Delta was different from Omicron. But as we move into the new variants that are out there, you want to give us some comments about that, in your opinion right now, David?
Yeah, so let me preface this. If you guys know, I'm pretty tough, right? I did 3 years of cancer. I had a trach. I'm pretty tough. I had a PE, horrible infections. And I'm going to tell you, I got sick at NMSP. And I got pop positive with a sniffle and a cold. And so I said, oh my goodness, I got COVID. So I started myself on Paxlovid with my physician's guidance. And I felt there's no way I could fly home. So we drove home from Tampa to Texas. So I got better very quickly. I really wasn't all that affected except for a man cold. And then 9 days later, I'm positive again and I'm sick. And so I had the rebound COVID after Paxlovid. And I'm going to tell you, I'm pretty tough. This really kicked my ass. I mean, I ended up with rails and mild hypoxia and short of breath. I'm working with my physicians here in town, got started on antibiotics because I was coughing up gross, disgusting stuff with a fever, rails, and worsening shortness of breath. So the question of the day is should we take Paxlovid or not? Should we be taking Paxlovid for 10 or 14 days to make sure that that virus reservoir that is popping up really gets knocked down enough? And what is the true incidence of rebound? So talking with some folks, the Paxlovid trials was done on the Delta variant, right? And the Omicron and this latest variant are very different, obviously. So the question is what should we advise people and our patients to do if you get positive? Should we giving Paxlovid? Should we not? Should we just tough it out? I don't know the answer. I can tell you that this new variant I think is a lot rougher than the other ones. I had COVID in July too. So to preface this, I've had 5 vaccines, 5, right? Including the double. And I had COVID Omicron in July of this year. And then I got this, what I presume to be the X11B variant, this time from my wonderful colleagues at Tampa. So what should we do is the question.
Yeah, so I don't know. And the problem is I was hoping that we would have either John or Osterholm on. If everybody else wants to kind of go check it out in your local areas, just to find out what you know from your ID people. And that becomes important, I think, for force protection, let alone, ourselves, put it that way. So I'd like to look at Ben. Are you hearing anything along those lines since you're one of our health persons here? Ben Weston, yeah.
All right, Paul, I got sidetracked. I need to.
Yeah, so the question is that we were talking about that maybe Paxlovid doesn't work with the latest variants, and it's quite different. And so the question is, should we give people Paxlovid going forward? So I was looking forward to seeing if we had some of our usual infectious disease people out, like Eileen or Mike Osterholm or even Shepke or something. So the ball's got to be passed to you for right now.
Yeah, I can't provide what Eileen or John Ju or any of them can, but I don't know. I don't know that the data that I've seen is definitive enough to say that particularly more vulnerable people or folks over 65 shouldn't be taking Paxlovid when they get an infection. I mean, the side effects are so mild, and the potential benefits and risk of not taking it so high. I think for the time being, we're still recommending it.
Yeah. Okay, David, now let's say that you get it, then you have the rebound. Should you take Paxlovid again, or do we, what's your opinion, at least at this point in time?
So the CDC and the FDA say don't. It doesn't provide any benefit. And I would agree with Ben. The side effects of Paxlovid are slim to none, right? You get the taste in your mouth, the metal taste in your mouth. Well, you feel like crap anyway because you got COVID. So I mean, it's not that big a deal. But the current guidelines is that you should not do another dose of Paxlovid. But my thought is if we're going to put someone on Paxlovid, maybe it needs to be longer, especially when dealing with viral disease. 5 days just seems a little short for me. Right?
Okay.
And think about it. How long do we put people on doxycycline for bronchitis and stuff? 7 to 10 days. Levaquin, 5 to 10 days, right?
Yeah.
So why are we only doing Paxlovid for 5 for a viral disease that we know has a reservoir of infection in the gut, in the lymphatics, and in other hard to reach places that we're not killing off, and then boom, you get rebound. So doing some more literature in this, the rebound COVID is actually common even in people that don't take Paxlovid. So you can get it and it can come back.
Yeah. Okay. Libby first, and then back to Ben. Hey, Libby, you want to make your comment?
Yeah, no, it was just that the research has shown that the incidence of long COVID is diminished with use of Paxlovid, but obviously that's for the more historic variants. I don't know about the subvariants right now.
That's what we're going to hopefully ask our infectious disease people. I'll try to ask them offline and make sure we get them on board, because I think John's unfortunately turned out he had to go to do a shift. Ben, go ahead.
Yeah, I was just going to say, I think to Dave's point, the challenge is it's not tailored at all. So everybody is the same duration of treatment, whereas, older people without as strong immune systems, certainly a longer treatment might be more helpful. But yeah, I think it's like twice as common in people who take Paxlovid, but the numbers are still low. So it's still not uncommon in people who don't. The rebound.
So David, how did you do? Are you over the hump in terms of your rals and so on, or whatever, people crackles or whatever was heard on you?
So I got better so this is day 7. So day 6-ish. I cleared the rails and the fever and the chills and all that stuff. And a lot of that may have been bacterial too. So I don't know.
Or something else.
Yeah.
Tell us about these various, there are 5 or 6 viruses out there that we could still also get beyond COVID, right? But what are some of the unusual ones that most people aren't aware of, but are very actually out there and not measured regularly?
Right. So RSV, believe it or not, can happen in adults. In fact, I pronounced somebody dead just last week, a 97-year-old in a nursing home who ended up having RSV. Adult metapneumovirus is another one, and that'll give you a cough for a month, right? It's almost like pertussis. We're seeing the adenoviruses, flu, all the normal winter flu viruses. But and I think if you look at the data from my institution, we only do the 20-panel biofire on people that are being admitted. And a lot of the little brats that we're admitting to the hospital have 2, 1, 3 different viruses, and they're acutely ill with flu and COVID, flu and adeno, COVID and adult metapneumovirus. So I think that it's pretty tough to figure out what's going on.
Part of adult metapneumovirus is not a common, in most people's portfolio and all that. And maybe if we come back, I may have you do a brief presentation on it, because it is kind of unique. And also, hopefully that's when we have our infectious disease folks on at the same time. So if you don't mind doing that, David, that'd be fantastic. Okay. All right.
Hey, Paul.
Yes,
quickly.
Yes, Pete, go ahead, Ray.
A quick announcement in case you don't know already, the Hopkins COVID website is shutting down in about 2 weeks.
Okay. That's because the epidemic's over, right? But the
Who,
bug
who
will be.
knows? Funding thing, who knows?
Yeah, no, that's probably what it is. Well, oh, by a good point, though, that brings up an issue is that, you know how you can go down and get a free shot right now? Are you able to go down and get a free shot in about a month or two, David?
Nope. So a
Yeah.
lot of the
so-
funding are going to go away. And even today, if you go get Paxlovid, they will run your insurance first. It's not the free government like it used to be. So when the health emergency ended, there's a lot of funding changes, both with vaccines, meds, treatments. And as you all know, we don't have any monoclonals that are approved for use. And even worse, we don't have Evishield anymore. So all those patients that are immunocompromised, cancer, on the biologics for psoriasis, arthritis, and every other autoimmune disease, all those patients now have zero antibody coverage because it's ineffective. So it's really a kind of we're in a time where we really don't have a lot of options. I think that hopefully the COVID is going to be becoming more virulent as far as more catchy, but less causing disease. But I don't know that that's true.
Okay. All right, I think we should probably switch gears a little bit here. I want to go around the horn. Anybody else on a deadline here that has to get off here pretty soon? I was going to go to Meg Marino next, but anybody else want to pipe in because they may have to go?
Paul, while I have the floor, I have just one thing to add.
Yeah.
So I just redid this for all of us that are EMS certified. You have to get the EM cert done, the EMS cert. I completed that process over the weekend and I was pleasantly surprised. I was very pleasantly surprised of how well it was done. The topics were timely. The information was right out of the textbook if you read the chapters or in the readings that they recommend. And I thought the exam was very well put together with stuff that matters, not minutia. So for those that are going to do that, a couple of recommendations I would have. First of all, download the study points from the website. Look through your textbook on the areas that you might have some challenges on. Read the articles that they give you very carefully in advance. Highlight the key points. What were the key findings? Highlight those so that when you go take this test, you can do it in an hour, right? They give you 4 hours to do it. But if you prepare, you can bang through this test very easily in an hour, hour and a half. So I will put the Dropbox links for all the articles that are on the exam that are referenced. I downloaded all the articles. I'll put them in a Dropbox so you can upload them yourself. And hats off to the folks at ABEM that worked on this. I think they did a great job.
Yeah, and Doug Kupas thanks you because he's on the sub board. So and he's also offered to help out in the past if anybody needs any guidance. One thing it's so pleasant to hear you say that because I was always very frustrated by the exams that we first took. I remember the first time I took the exam, there was one question was it was I was one of the authors, the senior author on the chain of survival thing, and the point was that it was the point was that you need all these things for the system to work, right? And then the question was which one is most important? It was like which one would you initiate first? And so I'm sitting there going, the point of the article was to have everything at the same time, do all the above. And so sometimes it's frustrating because I didn't know what the answer was. And, sometimes there were so many other questions there. And do you have to answer the questions about when the Stafford Act was in there or anything like that, David?
So to be perfectly honest with you, if you look at the study guide, they do want you to know about key regulations. For example, what's the EMS Compact? What agency, what was the Protecting Patients Access to Emergency Medications Act of 2017? That's the DEA thing for EMS that Dr. Manifold and a bunch of people on this call champion. So there are some of that stuff on there, but they're straightforward and it's things you should know.
Right.
If you don't know it, this process will help you to be a better EMS physician. So I thought it was a very good. So download the study points. I'll give you the articles and just go for it. And if you need to know what you need to do, as Doug Kupas said on his video, then just go to your ABEM portal. It'll tell you exactly what EMS certs you have to do or what LLSAs, and you can get through the process pretty easily.
All right, you're the best as usual. All right, thanks a lot. So let's move on to Meg and then Jim Augustine, if you don't mind. Okay, unless someone else is urgently gonna have to get off, I'm glad to talk to others. So, but I try to get around to everyone. Okay, so go ahead. So let's start with you, Meg. What's happening in NOLA?
Hi, Paul. Thanks for all you do. New Orleans is in the middle of Mardi Gras. We had our first weekend, which was successful and uneventful. And we always think of that as like the practice weekend for our big event, which starts tomorrow. So tomorrow through Tuesday will be all day parades, and we'll let you know how it goes, but we're excited and we feel prepared and ready for the big event.
Yeah. Okay. It's actually more challenging when it's a movement as well. You know, for example, there are challenges in a stadium going up a high rises or whatever. You're trying to find people and all that, but this is also a moving target where things go along and anything can happen. So tell us about what in the past have been 2 or 3 of the bigger issues. For example, some of the I forgot what you call those. Each wagon or whatever. Yeah, which each float goes. And sometimes you've had problems with some of them falling apart or something else or getting loose or whatever. But tell us specifically what some of the, let's say, the most common things that you've said or the most concerning things that you've dealt with in the past.
So I think the most concerning thing is in 2020, we had 2 people struck by floats who were both killed, which was absolutely horrifying. And so finding ways to make sure that that doesn't happen is really important. We often see people fall off of floats or fall off of balconies. Those are pretty common Mardi Gras injuries. And then, of course, we see a lot of people who have overindulged in alcohol or other substances. And so I think that's probably our most frequent call. But thankfully, we have our sobering center to help us with those. And we even have a van that drives around to pick up drunk tourists and bring them to a safe place. So we're prepared and ready to have 1 million people descend on our city over the next 5 days.
Okay, not 1 billion, but 1 million. Okay, go ahead. Yes, question.
Yeah, Meg, I'd be curious to see your blood distribution after Mardi Gras. Are you going to see a spike in whole blood? I know you guys don't use whole blood, but in blood administration. I recently saw your numbers and they look incredible.
Oh, thank you so much. You know, we unfortunately do see a spike in violence around this time because people will use Mardi Gras parades as an easy escape route to target particular people for gun violence and then run away in the crowd. And so I hope that we don't see that this year, but we are prepared for it with additional blood medics out and about.
Are you also going to, you've had in the past issues with people who are being abducted as well at those events, is that right? How often does that happen?
You know, that is less frequent. We always do, just like any large mass gathering event, you'll see an increase in human trafficking at these large events. But abductions seem to be pretty rare.
Okay. Well, good to know. All right. Well, listen, thanks a lot. Would you do is give us a report next week to see what you did experience, if you don't mind, or is you're right in the middle of it though on that Tuesday next week, right?
On
So
Tuesday, I won't be available on Tuesday.
Right.
We'll be right in the middle of the mayhem, but the following
2
week I'd be
weeks.
happy to.
Yeah, that's what I'm getting at. That's what I meant. Okay. All right. Well, listen, thanks a lot from our point of view. It's always great to hear from you. So I appreciate it. It is an interesting challenge for you. Jim, and then I may go to Mick Malloy. Jim Augustine, anything to report on from your end?
Hi, Paul. I'm sure you and Peter reported, but seeing that shirt on you reminds me we're at the 5-year anniversary. So condolences to all of you and your community. The big issues of the day.
Actually, if you this, I was going to say, if you see the invitation I sent out today, yeah, I give a latitude and longitude, and that's actually this park where I'm sitting right now, where the high school happened. I'm up here, right there, and that's what the location was, because I changed it from others. So yeah, so any event. But go ahead. I'm sorry to interrupt you.
Yeah, we did our major shooting training today in Cuyahoga County. So can't forget those kids and what you all went through. Okay, a couple things regarding COVID. The end of the public health emergency is going to change things. I sent out a note through the IFC about local changes in public health and flexibilities and funding for a lot of the medications testing and other services we have received. So that's out there for the fire chiefs. I just got a couple minutes ago the drug shortage list, and it has gone up to 111 lines, different types of preparations that are in shortage. We were expecting it to go down, it's going up. And albuterol is the key one. Now, what happened today, we think one of the manufacturers may come back online in March with production of nebules of albuterol. That would be a help to all of us and to people in their homes that have to use that medicine. Otherwise, the fear is we'll get to our albuterol months, if you will, which start, mid-March-ish across the country. And people won't have access to albuterol, and instead they'll call EMS for their Q6 hour treatment, or we'll be setting up albuterol rescue stations in the community. We told the FDA to please update us and be aware of how important this is, both in the emergency world as well as in the home care environment, and that this kind of a shortage of medicine that's this important, used by this many people, shouldn't be a surprise to everybody, but it was. The other medicines that are on there is our usual list, Paul and group, and we just don't have any news to say on the good front about what may be coming in the drug shortage world. So thanks for letting me report.
Okay, anybody have any questions for him? If not, then let's pop over to the evening news from Ireland. So what's happening over in the land of my ancestors?
The land of your fathers. We are preparing for the beast from the east at the moment. So we're going to have a polar vortex, and temperature is going to drop by about 20 centigrade over the next couple of weeks.
And how long is it expected to stay that low?
7 to 8 days.
Wow. Okay.
Yeah, so it's just going to be stuck on top of us, and unusually expecting up to 2 feet of snow. And we haven't had snow in 7 or 8 years. So it's going to be interesting. The last time this happened for me here, we had the local farmers picking the staff up and driving them to work, because not everybody can get up and down the country lanes in their regular cars with that kind of snow. We don't have snow plows generally, so that kind of clearing roads doesn't exist. So the farmers did rotas and brought the people into work, which was fantastic from a community perspective.
So when is it supposed to hit?
Friday morning, I think.
All right. Well, then I guess if you'll be reporting from 10 feet under. That's right. Is it supposed to hit certain areas worse than others?
No, it's a pretty big, what do you call it? Pretty big system. So it's probably going to be 3/4 of the country.
Oh God, well, our prayers are with you. It's unbelievable.
I know we don't have anybody from New Zealand on the call. I have a couple of buddies over there. They've had 95% of their annual rain in 2 days. So the city of Auckland is underwater at the moment, and their whole country is in pretty much a disaster zone from the flooding perspective. They don't really get that kind of floods. So there seems to be a lot of very unusual weather systems happening this year.
Craig Ellis was going to try to get on, but I think he's busy dealing with all that right now. So I'm glad you brought that up. It's the worst, I think one of the worst storms they've ever had, worst cyclone, and it just sat there for a while. That's what the worst part was, so it didn't move. I know it got there quickly, but then it stalled out over the over this of the country, and it just is awful. So, well, it looks like there are more and more weather disasters happening long and short of it across the world. So we'll keep an eye on that one. So we even had one down in the area of South Florida, right, Carolina? How are things going on that end? Are you guys still, let's say, unpacking, so to speak, and tacking up again?
So honestly, we're looking pretty good at all things considered. Certainly, it's Fort Myers Beach that got hit the hardest.
Right.
It had some of the oldest infrastructure, if you will. So Fort Myers Beach is going to have to do quite a bit of rebuilding. But the rest of the county looks pretty good. We're back up and running like normal. All of our infrastructure is up and running. We're definitely having a lot of problems with ED boarding that seem to be getting worse. But I don't think that I can attribute that to the storm. I think that that's fairly universal.
Attribute that to the world, yes. Yeah.
And a lot of the hospitals have actually started to reach out to try to talk about EMS level loading, which realistically already happens. But it's all stemming from ED boarding. So we're seeing quite a bit of that. Other than that, the storm seems to have
Were there any
resolved.
major lessons learned from the storm now in retrospect that you would do different?
I would do different. I don't think I anticipated at the time how many mental health effects our providers would have from the time when we had to shut down services.
Yeah, interesting. So you're feeling like they felt, I don't know if the right word is guilty, or just letting people down, that they couldn't be there to help them? Is that what you mean?
I mean, I think it's the, like, I was talking through it with one of the we have a clinical social worker, not a social worker, a licensed clinical therapist who works for the department. And we were talking about the like helplessness that comes from that, like just not being able to help in that moment. And like, certainly we're in a helping profession, and in the just like you guys were talking about, in that moment of do people just get up and do. But I think that was one of the things that I didn't anticipate, was that during the time when the storm was hitting, there wasn't anything that could be done. And the mental health impacts of that certainly, once we could get up and doing, we certainly did, but I don't think I anticipated that.
Yeah, that's actually a widespread and time-honored problem that people didn't talk about before. Is the difference, sometimes, or they express it in different ways. They get angry, or they'll get, whatever. It just there is, So I'm glad you got to see that, because it's an important thing to anticipate and be aware of, and so on. And sometimes counseling them ahead of time is to be mentally prepared for it. Helps them out a little bit better, So. All righty. So Peter, that kind of goes back to a little bit of what we were talking about the event here 5 years ago too. It's that feeling like you wish you could do more. That kind of, it just was a common, it's a common thing. It just and part of the job is what it affects. Because you're held back from not going in if it's an unsecured situation, for example. So it applies to a lot of the disasters that we face. So yeah. All right.
Yeah, and I think that what I've learned, if anything, in this field, is that doing things on the front end and preparation, things like the training, getting whole blood, all the stuff we're doing before the event is much more important than anything you can do the day of. So, as a medical director.
Yeah. So it's interesting. And Peter, you see what I was wearing today, right? So just for your sake, so as well. Hey, one of the things I was going to say about that is that one of the things that I think, if any of you heard at NAMSP, Peter was on a panel when we talked about minding the mind of EMS. And one of the things he's learned is that people used to get the most upset, of course, all of us do, including myself, when there's the vulnerability is the children, a young child dies, and even if you couldn't do anything about it, it still is the most upsetting thing. But Peter, tell them just like in about a 1-minute spiel, what is one of the things you did to address that issue of, because people go into this volatile situation with families screaming and whatever, those kinds of things, right?
Yeah, thanks, Paul. I basically mentioned that the pre-arrival portion of any pediatric scene, what we've learned is it's more important than the actual on the scene time, meaning that if you're prepared mentally with what you're going to do, you could actually look at the family in the eyes, you could keep everybody calm. Over and over again, you hear people who get to the scene of a pediatric call, and in their mind, there's a lot of yelling, screaming to leave the scene. But in reality, it's because of their own internal behavior and how they're acting creates the people around them to respond in a very kind of hyper aggressive way. So pre-planning before that 6 to 8 minutes before you get to the scene is more important than any point in the entire scene. That's what we've learned.
Let me make sure everybody understands when you say pre-planning, what that means is as a group, it's almost like it's like a huddle, in a sense, before you're going to play, correct? So
yes. And the same thing that we would do in the emergency department when we hear 5-minute ETA of a 3-year-old drowning, right? We're basically huddling, everyone's got their assignments, and everyone just does the thing so that, if you're really looking at your system and a pediatric code is being done correctly, you shouldn't be hearing anyone speaking, except maybe to the family member. And that's pediatric code done well.
Okay, great. Well, thank you for that comment, etc. Let's see. Hey, Stein, before I forget, do you have any time maybe tomorrow or Thursday, possibly Thursday, I guess, to get together and finish off the survey?
Yes, I can make time on Thursday and we can get a hold of each other.
Yeah, let me know what's good for you. What was the earliest I could get a hold of you? Because I'm 2 hours ahead of you.
Let me look at that and I will text you.
All right, fantastic. Okay, good. Angus, anything else to report from across the state of Florida? If you're there, Angus.
Hey, sorry, I'm multitasking. No, nothing significant from here, other than to say I will not be with you for the next 2 weeks because I will be far, far away on a sailboat.
Oh, cool. In a galaxy far, far away. What part, can you tell us what part of the globe, or do you want to keep that low key?
That's on a need to know. I'm just kidding. British Virgin Islands. I'm going sailing. So
which one? Which island?
British Virgin Islands. First vacation
before COVID. BVI themselves. That sounds good. Excellent. Good for you. All right, Wood. Thanks for that brief report.
See ya.
So, okay, I'd rather be sailing, he says, right? Okay, good. Hey, I'll just go down the list real quick. Ben, anything to report out of Milwaukee that we should know about, or?
The things that come to mind are, we released our dashboards. I showed that last week. We've gotten great feedback from EMS agencies, hospitals. We were a little concerned, anytime you do too much transparency in data, what sort of feedback you're going to get, but it's all been really good. And then the other thing front of mind, I think, is opiates. We got our opiate settlement funds, several $1 million. So we applied through the county for quite a bit of that, and it looks like we're going to get it to do a lot of initiatives, field buprenorphine education, data, harm reduction kits, things like that. So,
all right, excellent. Hey, Dustin, how about Cincinnati? Dustin, are you still there?
Sorry about that, sir. Also multitasking and driving.
Yeah. What's on your hat?
It's
more important. I see what's on your hat. What's on your little
cap? Cincinnati Fire.
That's what I thought. That's very cool. Good. That's what I wanted to see. I want to make sure we point that out. Go ahead.
Well, the main reason for that is that the only thing that I have that's of interest to anyone outside of Cincinnati is that after feels like 20 years of trying, the Cincinnati Fire Department has decided that the physician does need a physician response vehicle. So we were successful in getting that.
Yay.
So any of you who don't have one and are looking for a new argument, the fact that Cincinnati, that's always 10 years behind everybody else, has one, there's a new arrow in your quiver there, but that's about the only thing interesting I have for us today, Paul.
That's a justification of all justifications. That's great.
Yep.
I'll keep that in mind. Hey, by the way, did we ever find out anything more? They kept it hush hush about what happened and how things transpired on the field that day with
No. So there are some background legal doings that are going on to see exactly what can be talked about. I know there's some possibility of some folks putting together a presentation of, what went well, what didn't go well on the field itself. That obviously is going to take some thumbs up from both our health system as well as the NFL. So as that develops and I hear more of what can be shared, I'll definitely put that out there. But as far as actual etiology, I have been able to dig up nothing other than what's pretty much publicly available.
Yeah. I'm just curious if you happen to know. So I knew it was a shot in the dark, but here you are.
Yeah.
But congratulations on your vehicle. Don't wreck it.
Thank you.
Okay.
Yeah. Well, that's the funny thing, Paul, is it's a hand-me-down vehicle that the department said the only direction is keep a flare under the seat. If you get rear-ended, light the thing off and burn it down so you can get a new one.
Yeah. That's how I started out in 1982. Same way. All right. Well, listen, Cincinnati. I could say Cincinnati's finally got one. That's great. All right, let's move on. Jeff, anything to report out of Fort Worth?
Same stuff.
Okay, got it. Libby, anything from Hawaii?
No, nothing different. Thanks.
Good. Mark, anything in San Jose?
No, same old in San Jose.
Okay, good. All right. Thanks a lot. Let's see, Peter, we talked to Roger. Anything to add to the conversation?
So one of the new areas we've been working on is to try to separate out the medicalization of response to the dual response involving agitated patients. And we've actually created a response plan called I think it's POL Agitated 1, which is an automatic single ALS 1 or a single paramedic response. And we're trying to educate the police departments, first the county police, and now very recently, yesterday, we got a letter from the commander of the Rockville City, which is our county seat police, in which they're all trying to get on the same page on how to collaborate with our responses involving patients that they feel are agitated for a medical reason, and their understanding that those patients are destined for the hospital. It's in response to some of what's been going on nationally with dual response between law enforcement and paramedics, and we certainly want to keep our folks out of trouble and also deliver the best care that we can for what we think is a medical process and for which we think things like ketamine are lifesavers when they're used correctly. So that's probably the biggest news for the week out of Montgomery County.
So I want to go ahead and shut us down. Does anybody? I got to head up to the event that I'm standing by for. So I just want to see, does anybody else have anything of note or anything they want to mention or bring up before we get off?
Yeah, this is Stein. Just one quick comment following the prior is that the state of Colorado has now mandated that we do dosing of ketamine, not ketamine, any sedative at all, instead of non-weight-based. We have to do weight-based. And I sent out a survey actually yesterday to see from everybody if there is any standard of practice or something that people have out there that they think is accurate, because we really didn't want to move this direction, but we have to. We're mandated. At least we got them to agree that we didn't need to carry scales out in the field, which, believe it or not, was an initial requirement.
I have a comment on that. So as many people know, for kids, you can use the age to get ideal body weight. In the adult, you can use your height. The only way to really do that is two ways. You either know that you can either size them up and get their ideal body weight, or you just guess. And I've spoken to a lot of medics in the field asking this question, and most people just say they just randomly guess. So, but the right way to do it legally, if you will, and if you look at the New Hampshire protocol has an actual table in there, and it separates out into male and female, and it gives you a ideal body weight for adult males and adult females. And supposedly someone's going to look in that protocol and say, oh, you're 5 foot female, therefore you should weigh 50 kilos. Therefore, your dose of ketamine is going to be X, Y, or Z. So that's kind of the official way to do body weight dosing in adults.
One thing I thought might be helpful to, is that partially because of the Colorado experience and the Arizona experience with over legislation of medical practice, one of the things we've tried in Maryland to do is to try and keep the legislature informed, but give them sort of give them a description of what's happening. So what we're doing is we're actually doing, the legislature passed a study bill and a requirement for MIMS to report back to the state on the use of ketamine. And so what we're doing is we're giving the state data on 100% peer review of ketamine, and the state also has EPCR data that they're reporting back to the legislature. So we're doing everything we can to be transparent and make it so that the legislature falls short of actually passing laws like the one that was described in Colorado or Arizona.
So Stein, I would offer a variation of Peter's product. There are 3 adults, 60 kilos, 70 kilos, 100 kilos. Pick one of the 3 and dose appropriately, you'll be fine. Because a 25% variance is not a big deal with ketamine and Versed. So you got Abuela, 60 kilos. Normal person, 70 kilos. Everybody else in San Antonio, 100 kilos. So that would be my recommend to make it simple, 60, 70, 100.
So
and again, it's ideal body weight. It's not how much chunkamunka you got. It's your ideal body weight based on height.
And let me say this, David took the boards, and so as a result, he is the expert on this. I want you to know. So, okay, thank you, David. No, but listen, I like that plan anyways, because it does make it, anything you do to simplify it makes it better. So, okay. All right. Let's see, where was I?
I think Mick wants to say something.
Just a very quick comment. Number one, it's very refreshing to hear Americans talking in kilos. And number 2, I'd love to find that 100-kilogram man, because I left him behind so many years ago. I don't know where he is.
Yeah, someone asked Mick, they said, oh, he said, you lost a lot of weight. And he goes, where is it? Did you find it? Terrible. So in any event, all right. On that note, right, it's a good time.
Well,
So
Mick, you look great, my friend. You look great.
Yeah.
I did have a question for the group, and I was wondering, have any of you, and I hadn't heard it discussed, and I may have missed some of the meetings, but have any of you heard about whether other states besides ours, in response to what had been going on with the issue with the agitated patient, had also passed some sort of study bill so that they were kept informed, but without legislating the medicine? Is that something that any other state did, to anybody's knowledge?
Can you say that a little differently? Because I didn't understand the question.
So
for our study.
So the Elijah McClain incident, and then another incident I think involving an encounter in Arizona involving a lady who was apparently left after the medics diagnosed, and therefore there was a bill in Arizona that declared that medics can't diagnose, and that was discussed in Tampa. The idea of the state legislature legislating medicine, that caught the eye of legislators in different states. Some wanting to model some laws and maybe introduce some bills that were modeled after Colorado. And obviously Colorado's medical community did a great job of trying to push back. Maryland's response was they were looking into that, but they were held at bay, and they just wanted to understand the issue. So a bill was passed that required a report to the legislature. And I was just curious about whether other states had taken that path, because I wasn't familiar off the bat with any one besides ours. That's why I asked.
It looks like Doug.
Does that make sense,
Doug
Peter?
answered. Yeah, it does. That didn't happen in Florida, but Doug is saying that Pennsylvania required QI for all ketamine administration, and then reports go to the state quarterly. So is that sound like what you're talking about? Yeah. You're on mute, Roger.
Yes, that sounds exactly like a similar bill. If Doug had any comment about that, that's very helpful to know. I didn't realize our neighbors to the north had done that.
Hey, Mike, I'm ending up the call right now. Hang everything. Hey, guys, I gotta really shut it down, okay? So I will talk to you later.
Okay, I guess Doug and Roger can connect offline. All right,
Yeah.
awesome. Thanks, Paul. Paul, thanks for going tonight.
Yep,
Appreciate it.
I'm here. I gotta get out to the SWAT team. Okay, bye.
See ya.